Okay. So, good afternoon, everybody. Today, we are here to talk about obesity. And we have an expert today, Dr. Pamali Nanda, who is going to enrich us with her knowledge on prevention and treatment of childhood obesity. So, we're basically celebrating World Obesity Day on 4th March. So, this webinar will give us more insights to pediatricians as well as to parents as to how to manage and tackle this growing epidemic of obesity in our society. So the speaker for today is Dr. Pamali Nanda. She is MD and DM in pediatric endocrinology. She's presently an assistant professor at VMMC and Safdarjung Hospital in Delhi. She has had 18 publications in peer-reviewed journals, 5 book chapters, contributions to newsletters, and caregiver education materials. She has had more than 6 years of teaching experience, and she's also a life member of ISPAE. Moreover, we worked together in both at Maulana Azad and Kalavati. So let's welcome Dr. Pamali for this enriching webinar. I will stop sharing my slides and I will give it over to Pamali.
Right. So thank you for the warm welcome, and it's a I'm honored actually to have this opportunity to be having a session along with you. So I'll be sharing my presentation now. Is it visible? Is the full screen visible?
Yes, it's visible. Yes, go ahead.
Okay, so the topic for today is prevention and treatment of childhood obesity. Briefly, we'll be discussing the burden of obesity as to why we have chosen this topic. I'll be briefly covering the etiology and the pathophysiology of the various forms of obesity. How do we evaluate a child who presents to us with obesity? What are the various complications? How do we prevent and focus on the management? So why this topic? What is the burden of obesity? So it has been seen that there has been a more than 3 times increase in the percentage of overweight and obesity in the recent years. So as compared to 4% in 1975, currently 18% of children in the age group of 5 to 19 years are overweight, which is an alarming prevalence. A multicentric study, which was conducted at about 11 centers in India, found out that the prevalence of obesity and overweight in children was as high as 23.9%. So that means approximately 1/5 of the population. So in India, the data on infancy prevalence of infantile obesity is scarce. However, in children under 5 years of age, approximately 3.4% of children are overweight, and which increases to a rate of 4.2% in urban areas. And this has been a stark increase of 50% from the rates of 2.1% that was in NFHS for the last data. Among children, older children, so the prevalence of overweight and obesity is 4% and 1% respectively. And in adolescents from different regions of India, the pooled incidence rates have been found to be 3%, ranging from 3 to 24.7%, and obesity being 1.5 to 14%. With the COVID-19 pandemic, we all have seen that the rates of childhood overweight and obesity since the onset of the pandemic has increased by alarming rates. So what are the various etiologies of childhood obesity? So the most common cause of obesity in children is exogenous obesity, which results from a chronic imbalance between energy intake and energy expenditure. It has been seen that infants who are born small or large for gestational ages, who are born to mothers with obesity or mothers with gestational diabetes, they have been seen to have at an increased risk for childhood and adolescent obesity. And adverse metabolic programming is something that attributes to this phenomenon, and we will discuss about it in the subsequent slides. As opposed to exogenous obesity, the other group is endogenous obesity, which can be divided into monogenic, syndromic causes, and endocrine causes. So among the monogenic causes, these are basically single gene defects, which results from mutations or deficiencies in the genes which encode for the various genes or proteins which are involved in the appetite regulation pathway, like melanocortin 4 receptor gene, the leptin receptor gene, etc. Various genetic syndromes also predispose to obesity. The common ones that we know are Prader-Willi, Bardet-Biedl syndrome, and Alström syndrome. Apart from that, other syndromes like Carpenter and Cohen syndrome, Albright hereditary osteodystrophy, all these also have obesity as a predominant feature. Apart from these, endocrine causes like hypothyroidism, Cushing syndrome, growth hormone deficiency, and pseudohypoparathyroidism are also contributors to obesity in children. So the various risk factors for infantile obesity could be due to maternal factors, nutritional factors, and genetic factors. Among maternal or antenatal factors, increase or excessive gestational weight gain, that is an excessive weight gain during the pregnancy, has been found to be a chief determinator for obesity in children. Maternal preconception BMI, if it is high or if it is more than 30, these things have been seen to affect the rates of infantile obesity. Therefore, we say that to reduce the incidence of infantile obesity, the interventions have to start right from the antenatal or in fact the preconception period. The mother should be having an ideal BMI, and the weight gain also during pregnancy should ideally not be excessive and should be monitored. Apart from these, other conditions like we discussed, gestational diabetes, SGA baby, gestational hypertension, and conditions like maternal smoking also predisposed to infantile obesity. In SGA babies, what happens is that in the initial postnatal period or in the first 2 years of age, when they're exposed to adequate nutrients or nutritional adequacy, so they exhibit rapid catch-up growth, and these infants who exhibit inappropriately high rates of catch-up growth, they are found to be at a higher risk for obesity in childhood. Along with that, nutritional factors like overfeeding, bottle feeding, formula feeds with excessive of added sugars, etc., also predisposed to infantile obesity. Early addition of sugar-sweetened beverages and fruit juices have also been seen to be associated with the 4 to 5-fold higher risk of obesity. And exclusive breastfeeding is actually protective against obesity. So if the duration of breastfeeding is exclusive breastfeeding is less, it again predisposes to an increased risk of obesity in infants. Apart from that, genetic factors have a play in children who present very early, that is like under 5 years of age, with severe obesity. And these predispose to something known as monogenic or syndromic obesity, and such children will exhibit hyperphagia. Typically, they have hyperphagia or excessive tendency to excessive increase in appetite. So as we discussed, children who are SGA, who are born large for gestational age or born to mother with gestational diabetes, in these children, when they have an increased risk of adolescent and also early adulthood obesity. So what happens is that the chief molecule that is involved is the PPAR gamma, which gets upregulated, and this predisposes to an increased adiposity. So in childhood and adolescent age group, again, there are various factors which predispose to a higher risk of obesity. So individual factors could be like lifestyle related, endocrine related, genetic factors, etc. Then family and home factors. So the eating practices in the family, like if there is an increased exposure to high energy diets, high intake of processed foods, excessive snacking, consuming beverages with added sugars, all these predispose to a higher prevalence of obesity. Screen time, sedentary activities, and constantly watching the television or being engaged in video games, these predispose to unmindful eating or snacking during the screen time, and so these are also associated with obesity. So all these contribute to a high obesogenic environment. So this environment also influences the already genetic or the family background which is present. And again, physical environment indicators could be residential density, access to areas with green spaces, public transport, food environmental factors like access to grocery stores, fast food restaurants, etc. So all these predispose. Additional risk factors could be endocrine disrupting chemicals, which cross the placental barrier and affect the fetus. Then there could be postnatal leaching of chemical products like bisphenols, phthalates, etc. through the feeding bottles or diaper creams. These could result in epigenetic changes and contribute to obesity. Then parenting strategies. So an authoritarian and negligent parenting is associated with a higher risk of obesity. What is advocated is a authoritative, which is a responsive and warm parenting style without being too restrictive of the feeding practices. So that actually protects against the weight gain. Then food insecurity, low socioeconomic status, adverse childhood experiences, all these contribute to a obesogenic environment. So evaluation of a child with obesity. So what are the goals of evaluation? Firstly, we have to determine whether the child is overweight or obese. Then if the child is obese, so is there an underlying pathological cause? So to identify, it is important to identify the red flag signs of obesity. And after the evaluation for the cause, are there any complications or comorbidities that the child is having because of his obese condition? So obesity results from an imbalance between energy intake and expenditure, resulting in an excess of fat or adipose tissue. So how do we define obesity? In children below 5 years of age, overweight, we tell a child to be overweight when his weight for length or height as per WHO standards exceeds 2 standard deviations for his age, and obese when the weight for length or height exceeds 3 standard deviations. However, in children above 5 years, that is 5 to 18 years of age, as per IAP, we follow the IAP charts, and we tell as overweight and obese in girls when it is more than plus 0.67 standard deviation and plus 164 standard deviation for overweight and obesity respectively. Similarly, if a boy, the BMI exceeds 0.55 standard deviations, he is said to be overweight, and if it exceeds plus 1.34 standard deviation, he is said to be obese. So this is important because the standard deviation scores is important to remember. So because Asians or Indian population, we are predisposed to a higher risk of obesity or a higher cardiometabolic risk for the same BMI. So in Indian children, the cutoffs are actually low as compared to that for children elsewhere. So these are the IAP BMI charts for girls, the pink one, and the blue one is for boys. So in adults, the definition of BMI for overweight and obese is 23 and 27. So in children, the centile lines that we can see, the red line corresponds to the 27 adult equivalent line, and if a child has BMI exceeding this red line, he is said to be obese. Similarly, if a child has BMI which lies between the orange and the red line, that is between the 23 and the 27 adult equivalent, he will be labeled as overweight. So in girls, it is the 95th and 75th centiles, which corresponds to the obesity and overweight category, and in boys it is the 90th and 71st centile respectively. So often parents may not be aware that their child is overweight or obese, because weight is something which is seen as a status of health, and they may not realize that the overweight is actually a problem in the child. So it is always important to take a good anthropometry, and the BMI should be calculated for all the children above 5 years of age. However, BMI has its own fallacies, as in it does not distinguish between lean mass and the fat mass. And also, it has been seen that for the same BMI, Asians have higher body fat percentage. And also the fat distribution is different in Asians, as in they have a higher percentage of visceral fat or truncal fat. That is, they have higher central obesity, adiposity, and therefore Asians for the same BMI, they are at a higher cardiometabolic risk as opposed to the Caucasian population. So in Asians, calculation of BMI can actually underestimate the rates of obesity. So this was a nice letter to the editor that was published in the Lancet in 2004. So here we can see these are the photographs of the two authors in this article. So this is the Indian author Chitranjan Yajnik, and he is the other author, the second author, John Yudkin. So both were actually had the same BMI, that is 22.3 kg per meter square. However, on body fat analysis, we can see that the body fat percentage significantly differed. The first author, the Indian one, had a fat percentage of 21%, whereas the other one had a fat percentage of 9.1%. So this was classically known as the YY paradox, and again it corroborates with the Indian thin fat phenotype. That is, Indians in the Indian population or the Asian population, we have a higher visceral fat or truncal adiposity, and for the same BMI, we are at a higher risk. So newer measures are emerging as better or surrogate other markers of obesity, adiposity. So one such marker is the waist circumference. It directly predicts the visceral obesity and is strongly associated with risk of metabolic syndrome and cardiovascular morbidity and mortality. And the combination of BMI and waist circumference can therefore help in identification of a high-risk obesity phenotype. So these are the waist circumference centile charts that have been given by Khadalkar et al. And in the Indian population, if the waist circumference for age exceeds 70th centile, then this has been seen to be a high risk for for metabolic syndrome in the Indian population. In adults, in adolescents, this corresponds to a waist circumference of 90 centimeter in boys and 80 centimeter in girls. However, measuring the waist circumference may be cumbersome and may be difficult to do in a busy OPD setting. So other measures, recently the risk circumference has been used to identify children with a higher metabolic risk. And again, the 70th centile has been taken as the cutoff to screen for hypertension. It is easier to measure and is more socially acceptable. And reference charts are available for the risk circumference for Indian children, age group 3 to 18 children, which have been published by, again, Khadalkar et al. Other measures for body composition analysis, for example, DEXA and bioelectrical impedance analysis can be used for measurement of the body fat percentage. DEXA has a higher sensitivity and specificity and is accurate and easy to use with a low radiation dose, but being expensive and also because trained operators are required. So the current use is more limited to research purposes in our scenario. Bioelectrical impedance analysis, although it is less accurate, but it is routinely used and is easy to use and has a relatively lower cost. So once we get a child with obesity, we need to take a thorough detailed history as to what was the age at onset of the obesity, how has the rate of progress been, what has been the duration of the weight gain, and history suggestive of underlying etiology like hypothyroidism, headaches, cranial pathology, and radiation exposure should be sought. History suggestive of complications like polyuria, polydipsia, snoring, daytime somnolence, headaches should be asked for. The birth weight should be asked. Family history of obesity, type 2 diabetes, any other cardiovascular diseases, stroke, etc. should be inquired. A thorough developmental history should be taken, and the dietary history has to be taken very carefully. It has to be a 24-hour dietary recall method. Intake of junk food, sugar-sweetened beverages, fruits, vegetables. How is the appetite of the child? What is his personal history? Does he follow a active or a sedentary lifestyle? Any history of any intake of any drugs, screen time? All these should be thoroughly inquired. Examination of an obese child, after the anthropometry, other things that should be examined include blood pressure. We must look for any features of Cushing syndrome, for example, purple stria, if there is any moon fishes, hirsutism, etc. If whether there is any evidence of acanthosis, that is the velvety or blackish discoloration of the folds, which is usually seen in the nape of the neck, in the axilla, elbow, etc. Presence of goiter should be looked for, as it could point to underlying hypothyroidism. Any evidence of tonsillar enlargement could point to obstructive sleep apnea. Pubertal assessment for adolescents or children above 8 years of age, pubertal assessment should be done. Any evidence, neurological examination should also be taken. Fundus for papilledema and presence of sixth nerve palsy could be a pointer towards pseudotumor cerebri, which is a complication that could occur in these obese children. Hepatomegaly could be a pointer towards non-alcoholic fatty liver disease, and hirsutism in an older girl could be a pointer towards polycystic ovarian syndrome. So exogenous obesity versus endogenous obesity. For endogenous, there is no age predilection. It can occur at any age, and especially if the child is very small, very young, less than 5 years of age, we should suspect an underlying endogenous cause also. Exogenous obesity is gradual to progress, whereas endogenous there could be sudden or rapid increase in weight. A family history could be present in both the conditions. Exogenous in exogenous obesity, family history is usually present because the family is exposed to the same obesogenic environment or the socio-demographic factors. In endogenous, if there is a particular pattern of inheritance, then it could be a pointer towards any underlying syndromic or monogenic causes. So on examination, children with exogenous obesity, you would see that the stature is maintained. So they will have a proportional increase in weight as well as height. The fat distribution usually would be proportionate. However, in endogenous obesity, there could be a faltering of height also. So the growth could be affected and the height would may be affected too. And fat distribution would usually be disproportionate. In exogenous obesity, usually these are not accompanied by dysmorphic features or neurodevelopmental delay, which however could be present in endogenous obesity. And the bone age could be delayed if there is some underlying endocrine cause of endogenous obesity. So it is important to look for and rule out any red flags in history and examination. If there is short stature, as we discussed, if the age of onset of obesity is less than 5 years, if there is lack of satiety, the child is never full, and soon after a meal, he is again hungry. So that is something known as lack of satiety or hyperphagia. Or if there is impaired development or dysmorphism, all these could be pointers towards syndromic or monogenic or endocrine. That is, all these are causes of endogenous obesity. So for hyperphagia, typically these children with endogenous obesity, they will have an increase in appetite, which is pathological. So even children with exogenous obesity, if you inquire, they will have an increased appetite. But in endogenous causes or syndromic or monogenic causes, the hyperphagia would be pathological. So there are various questionnaires also to actually score the hyperphagia. If the child is having is never full, is always hungry soon after a meal, is seeking food from trash, is also asking he eats food even out of trash, and is also taking inedible items. He steals food, becomes aggressive when food is refused to the child. So all these actually define pathological hyperphagia. Then if we want to differentiate between monogenic and syndromic causes, both of them usually will present with severe early onset obesity and hyperphagia. However, in monogenic causes, usually there would not be any other associated congenital anomalies. The development would be normal and it would be an isolated obesity. But in syndromic causes, there would be other systemic involvement, other congenital abnormalities, and developmental delay would usually be present in these children. So these are some examples. So this child has obesity along with polydactyly, and this could be pointed towards Bardet-Biedl syndrome. Here other features would include developmental delay, hypogonadism, retinitis pigmentosa, etc. This is a child with the typical facial features include narrow bifrontal diameter, almond-shaped eyes. So this is Prader-Willi syndrome. These children usually would have low birth weight and feeding difficulties in infancy. Later on, they would exhibit increased weight gain and hyperphagia and would be increasingly obese. So short metacarpals, short stature, hypocalcemia, hyperphosphatemia. We can see the short stature and the stocky build in these children, stubby short fingers. So this is a feature of pseudo hypoparathyroidism. Then children, we can have monogenic causes where children usually would be developmentally normal, would exhibit food foraging behavior, hyperphagia. These could be due to monogenic causes like leptin receptor, POMC deficiency, etc. Then history of hypertension, cranial irradiation, any CNS pathology, hypogonadism, delayed bone age could point towards endocrine causes. So all these red flag signs should be asked in history and examination to rule out any underlying endogenous or organic cause. So endocrine causes, as we discussed, one of them is growth hormone deficiency. So the child, along with short stature, they will have more of truncal obesity. And again, other features like typical facial features, mid-facial hypoplasia, delayed bone age, etc. This is a child who has, again, central obesity with Cushingoid features. He has moon facies, increased hair distribution over forehead, hypertension. All these would point towards Cushing syndrome. Hypothyroidism also, older children, they may present with obesity, and typical features of hypothyroidism like cold intolerance, short stature, goiter, etc. could be present. Obesity in children, it is important to look for other complications or comorbidities also. So all the complications that could affect various organ systems. For example, cardiovascular system, there could be dyslipidemia, hypertension, coagulopathy, etc. Then these children have increased incidence of steatohepatitis, non-alcoholic fatty liver disease, gallstones, etc. Then musculoskeletal. So it is very common in these children to have increased prevalence of bone pains, fatigue, etc. And other problems that could occur are Blount's disease, slipped capitis femoral epiphysis, and increased low bone mineral densities. Then endocrine, they can have complications like type 2 diabetes, polycystic ovarian syndrome, precocious puberty, early puberty, etc. And such children usually have poor self-esteem, depression, anxiety, and eating disorders are also very common in these group of children. So it is important to ask history to rule out these comorbidities and evaluate for them. So history of snoring, excessive daytime sleepiness, headache, awakenings frequently during the night could point towards obstructive sleep apnea. And history of jaundice, recurrent abdominal pain could signify NAFLD. Sudden weight loss without activity could be a pointer towards new onset diabetes. Then recurrent hip pain could point towards slipped capitis femoral epiphysis. Anxiety or avoidance of school could be a significant could be a marker of psychological effects due to the obesity. So evaluation, we should evaluate all these children to look for these complications of fasting blood sugar, and if the fasting sugars are abnormal, then OGTT should be undertaken. LFTs with enzyme should be undertaken. A lipid profile and ultrasound abdomen for fatty liver should be also done in these children. Then for suspected pathological cause or endocrine causes, you can do a thyroid function test whenever there are features suggestive of the same. Similarly, if the child is Cushingoid, then evaluation of the cortisol levels, and if it is high, usually these children, obese children also would generally have a high cortisol levels, but then they would be suppressed with a overnight dexamethasone suppression test. So if the child is actually Cushing's due to some other pathology, then it would not be suppressed, whereas children with simple obesity, it would be suppressed with a ONDST. Then if the child is syndromic, then other system examination, including fundus, hearing evaluation, all these should be undertaken. Genetic test as per need assessment. For example, if you're suspecting Prader-Willi, then a methylation sensitive MLPA, and if you're suspecting monogenic obesity, then a whole exome sequencing can be done. So it is recommended that for OSA, a polysomnograph for children and adolescents with obesity, and if they have at least one symptom of sleep disorder breathing, should be undertaken. For female adolescents who have menstrual irregularities, signs of hyperandrogenism, it is important to assess for PCOS. And for adolescents who are 12 years of age or older, it is important to annually evaluate for depression and other psychiatric disorders. A musculoskeletal examination should be done as part of evaluation in all children, and a high index of suspicion should be kept for idiopathic intracranial hypertension or pseudotumor cerebri, especially if the child has a history of new onset or progressive headaches along with significant weight gain, and it is common, very common actually in female children. So coming on to the prevention of obesity, it is important to start right from the very beginning. So in infancy itself, it is important to have optimal infant feeding practices, and before infancy, it is important that the nutrition of the mother should be actually healthy and adequate, and the weight status, that is preconception BMI, should be in the adequate range, and the weight gain during pregnancy or gestation should also be monitored and should not be too much. During infancy, it is important to have exclusive breastfeeding till 6 months of age, and breastfeeding should be continued at least till the age of 2 years. Formula feed is should be avoided if possible, and if mother's milk is not available, then pasteurized donor human milk may be better. Complementary feeding should be started at 6 months of age, and packaged food should be avoided. In the first 2 years of life, extra sugar and should be avoided, and the diet should not have any added salt, and sugar sweetened beverages, packed fruit juices, all these should be restricted in the diet. It is important to avoid forced feeding to the child and promote responsive feeding. That is, you should feed the child in response to the cues or the hunger cues of the child. And bottle feeding ideally should not be done. Careful monitoring of the growth of the infant is important so as to detect any early tendency for excessive weight gain. So a healthy eating environment should be promoted. An authoritative approach of parenting style should be promoted. The 5-2-1-0 rule is ideally should be followed. So what is the 5-2-1-0 rule? Basically, you should have 5 or more servings of fruits and vegetables daily. The screen time should be less than 2 hours, ideally, and physical activity should be done, at least advised should be for at least 60 minutes or 1 hour daily, and the intake of sugary drink should be actually 0. So this is a 5-2-1-0 rule that is very important to remember, and also counsel to the parents regarding the management or prevention of obesity in childhood. And physical activity is very important. It not only reduces the visceral adipose tissue, but also helps in increasing the muscle mass and has been seen to reduce the risk for cardiometabolic complications, improve the overall neurodevelopment and psychosocial as well as the skeletal health of the child. So for infants, the physical activity could just be the pulling on pushing of the child for floor play like crawling, etc. And tummy time should be given to these children for like 30 minutes per day. Then in toddlers, again, varied physical activities could be advised as per the developmental age, and at 180 minutes per day is what is actually advised. In children and adolescents, both aerobic and anaerobic exercises should be advised, and at least 60 minutes or 1 hour of moderate to vigorous physical activity per day should be advised. High intensity exercises or resistance exercises at least 3 times per week, and which is 20 minutes per day. They should be taking part in that. And active participation in daily chores, sports, or household work should also be advised to the parents for these children. In the school curriculum, there should be at least 30 minutes of exercise schedule per day. Then it is also important to emphasize to the parents the importance of duration of sleep and to have adequate sleep hygiene practices. So poor quality sleep has actually been seen, both poor quality as well as inadequate duration of sleep have been seen to increase the risk of overweight and obesity in children. So in children below 13 years, at least somewhere around 10 hours of sleep per day should be there, and above 13 years, the sleep duration should be 8 to 10 hours per day. As per IEP recommendations, again, less than 5 years, 11 hours, 5 to 10 years, at least 10 hours of sleep, and above 10 years, at least 9 hours of sleep is what is recommended by the IEP. Then for screen time, infants, as per IEP and American Academy of Pediatric guidelines, less than 2 years age children should ideally, they should not be exposed to any types of screens or televisions, etc. Children above 2 years of age, so for children 2 to 5 years, maximum 1 hour of screen time could be allowed in these children. In children 5 to 10 years, 2 hours could be allowed. And above 10 years of age, it has to be balanced screen time along, and it should not be actually uh, it should actually be balanced, and it should not be coming in the way of other age specific developmental goals. So it they can be allowed screen time, but then it has to be monitored by the parents. So coming on to the management of childhood obesity. So the goals of management include reducing both the weight gain and also improvement in the physical and psychosocial comorbidities. The short-term goal should be a loss of 5 to 10% of the weight, or 0.5 to 1 kg per week. And in the long term, additional weight loss is desirable. And it is more after the initial weight loss, what is more important is to maintain the achieved body weight over the long term. So management should actually be a multimodal approach, which should focus on lifestyle modification, dietary advice, regular physical activity, behavioral modification for the child, and then there is some limited role of medications and surgical options if indicated. So a stepwise evaluation and management strategy should be followed. So in children who are qualifying who are actually overweight and obese, after a thorough history taking and physical examination, if the child should be evaluated for comorbidities like we discussed, NFLD, dyslipidemia, diabetes, prediabetes, hypertension, etc. If there are no comorbidities, then lifestyle modification should be advised in these children. If there are any comorbidities, then along with lifestyle modification, the comorbidities should also be addressed, and the aim should be gradual weight loss. And then after the initial weight loss, it is important to actually maintain the the lower weight for a longer duration of time. If the child is not able to meet the desired goals, then we can consider additional treatment like pharmacotherapy or drugs and surgery. So there is the role of motivational interviewing, that is discussing with the child one by one, and interviewing the child, and along with that counseling of the child. So this motivational interviewing is actually a process. It should be engaging, focusing, evoking, and planning. So step by step, it is important to sit with the child and discuss with the child. So initially it could be a just a interactive process with the child, in which we get to know the child, and we can ask open-ended questions. It is important to be empathetic with the child and understand the issues that the child and the caregivers are facing, and where actually the problem is lying. We can identify that. Then it is important to focus on the problems of the child. So next process should be focusing on the areas which need improvement, and talking to the child regarding the habits of the child, and assess for the readiness, that is how motivated the child and the parents are to follow your treatment. Then evoking a behavior change in the child. So here you can actually empower the change within the child, and counsel for the various treatment options for the child. And lastly, planning. So it is important to set various goals for the child. So the goal should be actually realistic, and should be laid down in a stepwise manner. So something known as SMART, that is specific, measurable, achievable, realistic, and timely. So a proper treatment plan has to be laid out, and the various goals should be carefully outlined, and what should be the follow process should also be discussed with the child or the caregiver. And it has been seen that if during for motivational interviewing, if we carefully sit with the child and counsel the family, along with discussing the importance of the various treatment measures and the behavioral changes, lifestyle modification, then this has been actually seen to positively affect the rate of decrease in BMI. Then intensive health, behavior, and lifestyle treatment, that is IHBLT. So whom should we address it to? The patient and family in partnership with a multidisciplinary team, and promptly for a child or adolescent with overweight or obesity. And what should this consist of? One is the health education on multiple topics, and second is the behavioral modification and counseling. It could be undertaken in a healthcare setting, or even it could be community based with linkage to a medical facility. So, how frequently should it be done? So it should be a ongoing process across 3 to 12 months, and ideally at least 26 hours of contact time is required. It could be a group session or an individual session, or it could be both, and ideally face to face, or it could even be virtual behavioral modification or behavioral change counseling. So here motivational interviewing or training is used as the core component, and face-to-face is better. And if it is not available, even you can go for the virtual counseling. So what all actually should we counsel exactly in the dietary modification? So it is very important to stress on decreased consumption of fast foods, added sugar, sugar-sweetened beverages should be eliminated if possible from the diet. Reduced consumption of high-fat, high-sodium diet processed foods. In infants, as we discussed, breastfeeding, exclusive breastfeeding for 6 months, and then complementary feeding after that, and education on portion control. So this is what we already discussed, the lifestyle modification. So 60 minutes of moderate to vigorous physical activity per day, reduction in sedentary lifestyle, and screen time, which should not be more than 1 hour in children, and ideally less than 2 years children should not be exposed to any kind of screens. The 5-2-1-0 rule that we already discussed. Then after our treatment, what should be the goals of the weight loss or maintenance? So in children below 5 years of age, we do not recommend any weight loss. It is desirable to maintain the weight, and eventually if the child maintains the weight, then the BMI would actually come in within the range below the 85th centile for the age. In children 6 to 11 years, if they are overweight without any comorbidities, again we ask them to maintain the weight till the BMI falls below the overweight centile or the 23 adult equivalent. In obese children, again depending on the severity of obesity, you could advise a weight loss which is around 0.5 to 2 kilograms per month, or could be a target could be a 10% weight reduction. In children above 11 years, again overweight children, you can ask them to maintain the weight or have a very slow weight loss. In obese children, you can target again a 10% weight reduction of up to, which could go up to 1 kg per week. Pharmacotherapy or drugs, they may be considered, but as an adjunct to standard lifestyle modification. However, there are some caveats with pharmacotherapy, because the FDA approved medications, few medications which are FDA approved for use in obese and overweight children, they're only approved above 10 years of age, and long-term use has not been proven to be very highly efficacious as compared to the behavior modification. And also the long-term studies regarding safety and efficacy are actually very scarce. So there are certain specific indications regarding starting anti-obesity medications in these children. So if in obese children, if a formal intensive lifestyle modification program fails to limit weight gain or to ameliorate comorbidities, then drug treatment can be started. In overweight children, only if severe comorbidities persist despite intense lifestyle modification, particularly in those children with a strong family history of type 2 diabetes or cardiovascular disease. Anti-obesity medication should only be given along with lifestyle modification program, and only should be prescribed by clinicians who are experienced in their use and are aware of the potential side effects. It is very important to continue to monitor the child. So if the child does not have a more than 4% reduction in BMI or BMI Z score after taking anti-obesity drugs for a period of 12 weeks at the full dosage, then it is very important to reevaluate, go back and reevaluate the child, and maybe even consider discontinuing the medication. So as we discussed, there are options for pediatric population are actually very limited and only approved above 10 years of age. So some of the drugs which are approved are Orlistat, that is commonly used in children above 12 years of age. It is a lipase inhibitor. However, and it actually the problem is the gastric side effects and vitamin deficiencies that go along with it. Then metformin can be used in children above 10 years of age and is seen to could prolong the onset of type 2 diabetes in these children. Then off-label other drugs that are used are topiramate and phentermine has also been approved in children above 16 years of age, but only as a short-term treatment. Then other drugs include pramlintide, which uh, is a physiologic moderator of insulin and promotes satiety and mainly prevents postprandial hyperglycemia. Then GLP-1 analogs like liraglutide, which is approved in children above 12 years of age. Then metrileptin, which is a leptin analog and is actually approved for children in use with leptin deficiency. Then MC4R agonist like setmelanotide. So these are used in a particular group of children with monogenic obesity. So surgical treatment is actually recommended in children older than 12 years of age who meet strict criteria, like if they have class 2 obesity with significant comorbidities or class 3 obesity with or even without comorbidities, and only after a failure of a proper trial of intense lifestyle modification and pharmacotherapy has failed for at least 6 months. Then there are various kinds of bariatric surgery procedures that have been used. So one is the purely restrictive, where we actually bypass a segment of the foregut. These are like placing a band over the upper part of the stomach. So laparoscopic adjustable gastric banding. Then there are purely malabsorptive procedures, which reduce the functional length or efficiency of the intestinal mucosa. So these could include like jejunal-ileal bypass or biliopancreatic diversion procedures. Then there could be procedures which actually combine both these two procedures, like Roux-en-Y gastric bypass, sleeve gastrectomy, etc. So these are the various kinds of surgical methods. Laparoscopic adjustable gastric banding was initially being done very commonly, and here it involves placing a band over the upper part of the stomach. Then Roux-en-Y gastric bypass, where the uh, intestine is connected to the, we actually create a bypass and most of the part of the stomach is bypassed. Then this is the vertical sleeve gastrectomy. These are the procedures which are commonly undertaken. And it has been seen that the sleeve gastrectomy had a higher weight loss rate when compared to the gastric bypass and banding surgeries. However, the pitfalls with these surgeries there could be numerous complications, as in we are reducing the functional area of the intestine, so malabsorption, multiple vitamin deficiencies, including the B complex, vitamin A, D, E, and K, and minerals like zinc, etc., could be complications which are associated with these procedures. Then for underlying comorbidities and complications, it is important to promptly identify and institute treatment. For example, if a child has dyslipidemia, then atorvastatin or fibrates and niacinamide for hypertriglyceridemia should be started if the child has increase in lipids. Hypertension, again, it is important to identify and treat. And for type 2 diabetes, oral hypoglycemic agents like metformin should be started. Often, children who are overweight and obese present to us in the OPD with some derangements in the thyroid function test. They usually have a picture of subclinical hypothyroidism, that is an increase in TSH with between 5 to 10, and they would typically have normal T3 and T4 levels. So whether we should treat or not treat these children. So it is in these children, it is very important to counsel that the parents that obesity is actually a cause of these deranged thyroid function test rather than being a consequence of it. So here, unless the TSH reaches more than 10 or if there is a goiter, it is not needed. The subclinical hypothyroidism in these children is actually a consequence of obesity and does not require any treatment. It is only important to monitor the thyroid function, which would usually resolve in the follow-up with weight loss. Then some children actually present to the OPD with parental concerns of a small penile or phallic size. So when you evaluate and actually check the anthropometry, you would see that the child is obese, and it is not a small penile size, but an apparent small penile size, because the phallus or the penis is buried in the prepubic fat. So here also it is important to counsel the child, the parents, that it is not a true micropenis, and weight loss is all that is needed. Uh, Then certain tips for parents for or caregivers for prevention and management of obesity. Again, very important, diet and eating habits. The diet, it is not that you should restrict the diet. The diet should be a balanced, age-appropriate calorie intake should be advised. Sugary beverages should be avoided. You can counsel the parents, like they should promote consumption of whole fruits instead of fruit juices. For example, instead of orange juice, it is better to give a orange to the child. Then various health drinks or protein drinks, it is better to restrict their consumption, because these are usually rich in calories and sugar and have very little nutritive value. Then consumption of added sugar, high salt, high sugar, that is HFSS diets, which are high fat, high sugar, salt diets or processed foods, should be avoided. And for milk, it is better to ask them to consume low fat or fat free unflavored milk. Then a traffic light diet plan is what is commonly advocated and should be advised to the parents. So what is a traffic light diet plan? Here, uh, the foods are categorized into green light foods, yellow light, and red light foods. So green light foods are ones which are low in calorie, low in fat, are high in nutrients, and are high in fiber. So these are like fruits and vegetables, and these are the green light foods, and they should be taken in plenty or unlimited amount. They can be consumed. Yellow light foods mostly includes the grains and the starches and the dairy. So here they should be taken in moderation. These are high in calories and fat and also nutrient dense. So these can be taken, but the amount should be in moderation. Then foods like fatty meats, sugars, junk foods, fried foods, processed foods, and sugary beverages. These are the ones which come in the category of red light foods. They are high in calories, high in sugar, high in fat, and have very less nutritive value, and they should be avoided and or restricted. And occasional, they may be given occasionally, but it should be very minimal. So for the parents, we can actually give them a chart and classify the various food items which is usually consumed by the family, and we can tell them that these are the green light foods, these are the yellow light, and these are the ones which are fall under the red light and should be avoided. Then it is very important to educate the parents about the concepts of portion control and serving size. So for foods with high caloric value, the serving size they can reduce, and for healthier foods like fruits, vegetables, they can have a increased serving size. And for educated parents, motivated parents, you can ask them to actually you can familiarize them with the concept of reading and interpreting food labels. So they could actually see the food labels and interpret the caloric value or the nutritive value of a particular food item. Then healthy eating habits, it is very important to encourage. The child should not be skipping breakfast. Avoid distractions while eating. For example, while eating, television, video games, all these should be asked to be switched off. And the family should be eating meals together. The meal should be timely, regular, and unmindful snacking or constant grazing is something that should be actually avoided. Then we talked about moderate and vigorous intensity aerobic exercises. So what are these exercises? So for preschool children, these are like routine activities like playing on the playground, walking, running, dancing, jumping, catching, throwing, or riding a tricycle. In older children, this could include like brisk walking, riding cycles, or even household chores like sweeping or cleaning of the house. Vigorous intensity is these are the exercises which are almost this like same as the moderate intensity exercises, only the tempo or the effort matters in vigorous intensity. This could also include vigorous dancing, martial arts. Then muscle strengthening exercises like tug of war, yoga, rope climbing, tree climbing, and bone strengthening exercises like hopping, skipping, jumping, and even running. So moderate to vigorous physical activity should be undertaken for at least 20 minutes per day, and ideally 6 minutes, 60 minutes or 1 hour per day. And it should be for at least 5 days per week. And the muscle and the bone strengthening exercises should be at least 2 to 3 times per week. Then parents, it is very important for parents to be as role model for their children. So children would usually emulate what the parents do. So healthy lifestyle choices should be a important consideration. For example, using stairs instead of using elevators, then walking or cycling rather than using cars. uh, Importance of healthy sleeping habits should be encouraged. So adequate sleep duration and healthy sleep hygiene practices, like no television or any other form of entertainment should be there in a child's bedroom, and all the screens should be ideally switched off before 30 minutes at least before the bedtime. So parents should cultivate positive behavior practices and identify themselves as suitable role models for their children. So in a nutshell, if a child comes to you and you have uh, with overweight or obesity, so it is very important to watch out for the red flag signs. Early diagnosis and management is a key to improve outcomes in these children. Diet and lifestyle modification, physical activity is a cornerstone of management in these children, and the therapy should be a multidisciplinary approach in the management of these children. So thank you.
Wow, that was a very comprehensive presentation, Pamali. Really amazing. I was mesmerized. You have just taught the entire topic very well, and you've covered all the aspects of obesity, right from proper taking proper measurements, proper diagnosis, and prevention as well as treatment. Very well, you enumerated the exogenous causes as well as the endogenous causes. So, in our daily OPD practice, we have to be really mindful whether we are treating with an endogenous or a monogenic cause. So, we have to send for the workup and, in fact, do a genetic workup for such patients. So, that was really well covered. And secondly, you very well talked about the 5210 rule, the traffic diet plan, as well as you also spoke about teaching parents about the different how to read food labels. So, since we are uh, growing from a developing country to a developed nation, we are seeing this epidemic of obesity. So, it is very essential that we teach our teachers, parents, as well as children how to read food labels, since junk food is a growing concern these days. So again, thank you, Dr. Pamali, for this amazing presentation. Very informative. I would like the audience to post their questions if they have any. Not many questions yet, but if you have your questions, here Dr. Pamali is live for you to answer. And thank you, Pamali, for the guidelines for the parents. We'll make a separate video and spread it across various schools and teaching institutions. Thank you for that.
Thank you. Thank you. It was a awesome opportunity actually. And if there are any questions, I cannot see any questions in the chat box, so I could take some questions if there.
Yeah, so I would also request you to kindly send those growth charts to me via WhatsApp, so I'll spread it across the groups.
Okay, sure.
Those BMI growth charts and wait for length and height growth charts that you were showing.
I'll share them.
All right. So I think we'll end our webinar here, and let's hope Pamali can give us more webinars in future for other endocrinological topics.
Sure. I'd be pleased. Thank you.
All right. With that, I conclude this webinar. Thank you from Devbhoomi Society of Pediatrics, RP Uttarakhand. Thank you so much. Bye bye.
Thank you. Bye.
Thank you.